Your host, Paul White.
Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're glad you joined us. Before we begin, I'd like to thank our sponsor, Aultman Health Systems. Today, Brad and I are broadcasting from our administrative offices, and our guest is Dr. Atul Qureshi. Am I correct on that, Doctor?
Yes, sir.
Okay. Cardiologist at Aultman Deuble Heart and Vascular Hospital. We would like to remind our listeners that today's program is also available on our podcast, which can be downloaded from the App Store on your mobile phone. Look for Health Matters with the Medicine Center Pharmacy, and you can listen to any of our programs anytime. So, Aultman Deuble Heart and Vascular Hospital is the largest group of board-certified cardiologists in Stark County who are committed to delivering scientifically based diagnostic and treatment options. Dr. Atul Qureshi is a cardiologist with us today. Welcome to the show, Doctor, and glad to have you back.
Yep, thank you.
So tell us about yourself and your role at Aultman Deuble Health and Vascular Hospital.
So I'm one of the 23 cardiologists that we have here. In addition to that, we have advanced physician assistants and nurse practitioners that participate in our efforts to help with cardiology care in our area. My particular role is that I'm the heart failure doctor for our practice, and my focus is on treatment of heart failure. So, that's kind of where I fit in.
And your specialty is, Doctor?
Advanced heart failure.
Okay.
Good morning, Dr. Qureshi. What are some common conditions that you see and treat at Aultman Deuble Heart Center?
So one of the most common things that we treat include heart failure, which is my specialty. In addition to that, we see a lot of atrial fibrillation, which is a common abnormal heart rhythm. We see a lot of things related to blockages in the arteries, something called coronary artery disease. Those are the three very common ones. In addition to that, we see other rhythm problems and some valvular problems like aortic stenosis and so on. So that's kind of, the overview of things. Obviously, there are rare diseases and so on that we come across as well, but what I mentioned are the common ones.
Okay. Can you talk about what congestive heart failure is?
Congestive heart failure is a situation or a disease where the heart is not effectively or efficiently pumping blood, and therefore you may accumulate extra fluid in different parts of the body, like leg swelling. Sometimes you can get short of breath because there's fluid building up in the lungs, and so on. So basically, a situation where the heart, which is a pump, is not able to do its job properly. And that's what congestive heart failure is.
So, what are some common conditions that lead to heart failure?
So, most common condition would be blockage-related heart weakness, or somebody had a heart attack in the past, and now they're left with a heart which is not effectively pumping blood. Other conditions could be high blood pressure, uncontrolled blood pressure could be another common one. Sometimes things like diabetes and obesity and sleep apnea and all of them above, those kind of things, they can combine together and creating a situation called heart failure with preserved ejection fraction, which is pretty much a situation where the heart becomes stiff. It is not weak, it is just stiff and cannot expand to fill up with blood properly. And that can lead to a heart failure situation as well. So those are a few common things that can lead to it.
Who is typically at risk for heart failure?
So I would say we are all at risk, I think, because I think, anybody who obviously has suffered heart damage or heart attack or has a rhythm problem, they already have a diagnosis of, something related to the heart, and they do not have heart failure yet. Those are the highest risk people. But we all are at risk, I think, unless we change our lifestyle and we, are consciously trying to help minimize our risk by eating healthier, losing weight. Um, we all continue to be at risk for heart failure. So some of the things we can do is, make a lifestyle change, even if you don't have any cardiovascular disease yet, to help minimize our chances of developing one, including heart failure in the future.
So are there measures people can take to prevent heart failure and cardiac disease in general?
Yes. So generally speaking, somebody who does not have cardiovascular disease yet should follow certain principles, which include, weight loss if they're obese, which would include participating in regular healthy exercise on a regular basis, multiple times a week, including healthy diet in their, day-to-day food, which includes, fruits and vegetable servings and minimizing red meat and high cholesterol products. Those will be some of the basic things in preventative cardiology side, or preventative things that can not ensure, but it can help minimize the chances of you developing a problem in the future, including heart failure. If you have a family history of heart disease in your parents or siblings or whatnot, then also being more extra careful in those situations and trying to go to your doctor early and making sure that you don't have any disease that you may not be aware of yet. And yeah.
We hear a lot about too much beef consumption, greasy foods, all that sort of stuff. What about seafood? I know there's some seafoods that are high in cholesterol, but
yeah, that's correct. I mean, I think seafood would be a healthier choice. Obviously, excessively consuming any product, anything would be detrimental to health. But seafood also contains some healthy fatty acids like omega-3 containing, and oily fish may be actually rich in those that may be actually beneficial. And one diet that has actually shown to help prevent or help the people with heart disease is Mediterranean diet. It has been studied in randomized fashion and so on. And the Mediterranean diet may have certain of these things like oily fish part of it, and some other omega-3 containing things like olive oil and walnuts and so on. So I personally would say that healthy. It would be healthy to eat fish in a moderation, and it would be better than eating red meat. Red meat in general has been shown to have negative consequences from cardiovascular point, and has been studied. And that's kind of what the conclusion of that is. So we can still eat red meat, but we have to be careful with the amount of and frequency of the consumption of red meats.
And what about the vegetarians? I know some people that are really strict vegetarians. And are they a step ahead of us, or us meat lovers? Okay.
Yeah. No, that's a really valid question. I think that people who are vegetarian are certainly, I think, ahead of certain, I think they're probably healthier, but I think eating some red meat and fish in moderation probably is what I would advocate for, because I think if you're eliminating a certain food group altogether, I think that I personally would not advocate for that. So my personal opinion would be, if God has created it for us to consume it, maybe we should consume it, and knowing the risk of excessive consumption or more than moderate consumption. And, I think staying within certain domain would be the best thing, I think.
Okay.
Doctor, what are common signs and symptoms of heart failure?
So, as I said initially, heart is a pump. It pumps blood. If the heart is not pumping blood effectively or efficiently, then blood, which is pretty much fluid, may accumulate in various parts of the body. It can lead to swelling in the legs, or sometimes it can accumulate in the lungs, leading you to be short of breath when you're trying to exert yourself. Waking up short of breath in the middle of the night when you try to sleep on a regular bed is a common sign. And if you are trying to sleep on your bed and you have to wake up in the middle of the night to catch your breath, or you are unable to lay down flat, you have to put pillows behind you to prop yourself up. Those are signs that you should reach out to your family doctor or your doctor immediately. If you have a cardiologist, reach out to them. And then sometimes it can be associated with other symptoms, like rhythm problems can come along with shortness of breath symptoms. So if you're feeling palpitations or lightheaded, dizzy, or some other iterations, sometimes it can come along with angina, chest discomfort. So you're having shortness of breath or swelling, plus now you're having chest discomfort of any sort, either tightness, pressure, or pain. Those could be signs that could accumulate, that could be associated with congestive heart failure. But most commonly, fluid accumulation and shortness of breath would be your classical symptom. Yeah.
Okay, doctor, it's time for our first break. You're listening to Health Matters with the Medicine Center Pharmacy.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Welcome back to Health Matters with the Medicine Center Pharmacy. Friends, just a reminder to stop by the pharmacy and talk to our pharmacist about our Health Matters membership savings program. We want to help you stay well and save money.
Okay, doctor, before the break, we were talking about common signs and symptoms of heart failure. Excuse me. I wondered, do men and women experience different symptoms, or are they similar?
So if they are manifesting heart failure or they have developed heart failure, the symptoms will be pretty similar, because at the end of the day, the heart is pumping in relatively similar fashion in both men and women. So after they develop heart failure, I would say that they would be similar for the most part.
Okay. We often get questions in the pharmacy when patients have an ailment or ache or pain, and anytime there's anything that makes my brain trigger as being heart related, it always kind of puts me on high alert, because I know we have a tendency to maybe think it's not what we fear it is, and we kind of downplay a symptom or whatnot. Do you see, is it any more popular for women or men to kind of overlook symptoms or think it's not serious? Do you have any feedback for the listeners on, how serious to take symptoms when you think something just isn't right?
I think that's a great question. I feel like some men maybe may downplay their symptoms and kind of tough it out, especially when it comes to chest discomfort. So if you're having chest pain, that doesn't feel right, don't assume it as that reflux or acid or something. And best to be checked out early, because time is muscle. Remember that. Time is muscle. So if you are developing a heart attack, and that chest pain is actually a sign of cardiac chest pain, it's actually a cardiac chest pain, then you may lose muscle. You may lose your strength of the heart while waiting to get help. So if something doesn't feel right and your chest is hurting, that would be certainly an early kind of go to the ER or something along those lines, or seek attention immediately or early. And also, if your legs are swelling up and you're like, oh, my legs this is new swelling, I didn't have that before, or I'm more short going up that flight of stairs, I didn't have that before. Those are also red flags, and I think you should reach out to your doctor or the ER, depending on the situation. But when it comes to the heart, you just can't waste time, as you said. It's like things can change in a second by second, minute by minute basis. It's one of those organs that, it's not like a thing on the skin. Now you're going to wait for a little bit. You could have a rhythm problem that could be the end of the story. So I think that, if you ignore symptoms, that could have life-threatening consequences. So reaching out early is usually the recommendation.
And just to clarify, identifying that you may have something going on, your best bet is probably to go straight to the ER, not hit an urgent care or something like that, correct?
That depends on your situation.
Okay.
I think if you're having significant chest discomfort, pain in your chest, then maybe the ER is your best bet, because you might be having a heart attack. And going to the urgent care may waste valuable time if there's a significant chest discomfort situation going on. Because if you're having an acute heart attack, you need to go to the cath lab. They need to open up your artery. So in those kind of situations, probably best if you passed out or you're feeling really, really dizzy or lightheaded, probably also best to go to the ER. But if there are milder symptoms, or you think this is just a little bit shortness of breath or whatnot, I think then you have to use your judgment, and maybe urgent care or family doctor visit may not be unreasonable in those settings. So obviously judgment plays a role in some of these things, but I would take some things very, very, very seriously, like for example, chest pain, passing out episodes. Those have to be taken very seriously. Everything has to be taken seriously, but I think those two could really be more critical for you.
So, I wanted to hit also on the fluid retention symptom you mentioned, if you don't mind. And I'm thinking of a couple things. So, I'm sure we've all seen people who've had extreme swelling around the ankles, and it's very easy to identify. But maybe if someone's in the earlier stages, would symptoms be like maybe they gain a couple pounds that they're not sure where they came from? Or maybe it'd be like when they're wearing socks, if they see like the indentations on their legs from the nylon or something. Do you have any other tips people might look for if they might have some fluid retention but are just now learning about it?
So swelling in the legs is a common symptom of congestive heart failure, but it can also be a symptom of other things. For example, veins becoming weaker with the aging process, something called venous insufficiency. So if your swelling is getting worse by the end of the day, and when you wake up in the morning, first thing in the morning, it is better, then it is possible that you may have a component of veins just becoming weaker and not being effectively getting blood back against gravity to your heart. So I think that if you have never developed indentation from the socks, and now certainly you are noticing that, then yeah, it could be that early onset congestive heart failure. It is the bad company that it keeps. Okay, congestive heart failure may not have just swelling. It may also be accompanied by some shortness of breath, or unable to lay down flat, and weight gain on altogether. So isolated swelling may not necessarily be present in congestive heart failure. If you have isolated swelling and you have no shortness of breath and you're sleeping okay and no exercise intolerance of any sort, no other cardiac symptoms, palpitations or anything, then sometimes it could be just a manifestation of veins becoming weaker, as I talked about, venous insufficiency, or sometimes even your medicines like amlodipine or Norvasc or hydralazine. Some of the pills that you might be taking may be causing some of the swelling, or it could be unrelated to the heart. For example, it could be related to the kidneys, where you're dumping protein in the urine. So a lot of different things can cause swelling in the legs. Certainly can be a heart failure related symptom or sign, but some of the nuances that I discussed, it's probably best to reach out to the family doctor or your cardiologist if you feel like this is new swelling, or my swelling is getting worse, and get more things worked up in related to your swelling.
Okay, what about hypertension in pregnant women? Can you talk about this issue?
Hypertension can be a common situation in pregnancy. It can be related to things like eclampsia, where you may have seizures, or preeclampsia. You may be dumping protein in the urine associated with the high blood pressure during pregnancy, or may have other issues like low platelet counts. That can be a critical situation. So if you do have high blood pressure during pregnancy, you will have to reach out to your obstetrician, as well as sometimes maternal fetal medicine, MFM. So they will have to collaborate in giving you the right medications to treat it and make sure you don't have any associated complications. During pregnancy, certain medications may be restricted, and certain specific medications to be used to treat the high blood pressure. But certainly, getting regular obstetric care during your pregnancy, as well as pre-pregnancy care, would make sure that your provider picks up that you have high blood pressure and treat it accordingly. So best thing would be to stay on the schedule as recommended, and see your obstetrician or your doctor regularly so they can pick up any problems and treat it.
Doctor, we know that smoking is bad and causes COPD. Does that lead to heart failure?
Yeah, so smoking can cause issues related to blockages and blockages in the arteries of the heart can lead to weakening of the heart muscle and heart failure. So the most common cause of heart failure, one of the most common causes is blockages in this country, in our country. And therefore, if we continue to smoke, we're risking heart attacks and worsening blockages. And I think that is going to, that ultimately may lead to congestive heart failure. So certainly smoking cessation will be key in helping to minimize the prevalence and incidence of congestive heart failure in our society. So, yeah.
Okay, so are the dangers of smoking the same as vaping, or vaping the same as smoking?
Vaping will also have nicotine and other chemicals. Smoke has like probably more chemicals, I think, in smoking. Both of them, we would recommend against both of them. So if you are vaping, we will like you to stop vaping, and if you're smoking, we would like you to stop smoking. So we would recommend against both.
It sure seems like more people are smoking these days. I pick up more cigarette butts in the parking lot than anything. Any trash. Okay. Okay. Hey, it's the bottom of the hour and time for the news. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy. Your host and pharmacist, Paul White. This morning we are talking with Dr. Atul Qureshi, and he is with Aultman Hospital.
All right, doctor, we've been talking about smoking and vaping and things like that and how it can be hard on your cardiovascular system and overall health. What about people affected by secondhand smoke? Do these patients have issues?
Yeah, I think that any smoke in any form would be detrimental. And actually, secondhand smoke probably doesn't even have the filter that this regular cigarette may have. And if you're getting a lot of that, that probably is going to put you at risk as well. So trying to avoid smoking, and if somebody's smoking around you, maybe have them go out, and maybe if they can stop, that'll be great. If not, then at least they should not smoke where you are, so that you're not getting exposed to the secondhand smoke.
Okay. I know you have a number of colleagues in your practice. For listeners just joining us, can you talk about how many colleagues and how many specialties you have in your practice and what they deal with on a daily basis?
So we have a comprehensive practice here. We have our general cardiology partners who pretty much deal with all aspects. And then there's specialists, which include interventional cardiologists, which they deal with putting stents in and dealing with heart attacks. Electrophysiologists, who are specialized in taking care of rhythm problems of the heart, including procedures related to it, like ablations and pacemakers, defibrillators. And we have imaging specialists that can look at MRIs of the heart and other imaging related modalities, and congestive heart failure specialists, which is me. I deal with heart failure and pulmonary hypertension in our practice. So that kind of we have all specialties kind of present in our group.
This may be a little bit off the track, but I guess, it fascinates me how we seem to have arrived in an era where, like you hyper specialize in one area. It seems to me like maybe you can correct me if I'm wrong, 10 or 15 or 20 years ago, if you were a cardiologist, did you kind of see everything? Or am I just misinformed?
The specialties have evolved over a period of years and decades. So you're right. I mean, now we have separate boards, like exams for these specialties. Okay, so you can take an exam and be certified, and the Medicare recognizes them as separate specialties for billing purposes as well. So, and we have different fellowships that we didn't probably have all of them before. So over a period of the last couple of decades or longer, the specialties have continued to evolve in all of these different aspects. Like we mentioned, structured training, exams, payer recognition, and so on. So you are right. I mean, if you are a cardiologist, even if you are a subspecialist, you would still be able to help assess a situation, even if it is not related to your specialty, and you may divert it to the right person. But if you see an electrophysiologist, he may still recognize failure and send it to the right person, or treat it if it is mild. So we have our strengths, but we are still able to cover the breadth of the the cardiology in general.
Well, I only add that I don't mean that to be offensive in any way, shape, or form. My question kind of comes from when I was on my pharmacy rotations back in the late 90s, I was at IU Med Center in Indianapolis, and I had the privilege of being on a cardiology rotation. And I just remember being fascinated just by how complex the heart and cardiovascular system is. So it makes total sense to me that, given all of the specialties you've mentioned in the program today, how it takes full concentration and attention on each area so that you can give the patient the best care they can get. So I just think it's fascinating how medicine continues to evolve. And maybe I hope that listeners today can realize that your training has gone above and beyond what we had even just 15, 20 years ago, probably. So.
Right. That's true. I would agree with that. So one thing I forgot to mention is structural heart. So we have structural heart that are interventional cardiology colleagues, which specialize in actually doing things like putting valves in the heart and clipping mitral valve and putting Watchman device on. So our electrophysiologists as well as our interventional cardiologists are able to do some of these procedures which go into the structural heart domain. That minimize the chance of needing open heart surgery in certain patients or who have prohibitive risk from open heart.
What is mitral valve prolapse?
Mitral valve prolapse is where there are two leaflets in the mitral valve, a front and a back leaflet. They're supposed to meet in the middle. When the valve closes, they're supposed to meet in the middle. If they're not meeting properly, they kind of bulge out towards the top chamber called the atrium. So instead of meeting solidly in the middle, they kind of bulge backward. And that backward bulging motion is called prolapse. It can be associated with leakiness of the valve. So if you have a door in your house, in your room, and you want to close the door, if the door keeps on swinging to the other side, it won't close. And there'll still be a gap between where you can pass through. So that's kind of what prolapse is.
Wow. How about some of the latest developments in heart failure diagnosis and treatment?
So heart failure has been rapidly evolving as well, like other specialties in cardiology. We have new medications out there nowadays. Some of the medication that you might have heard about is the Entresto or sacubitril valsartan medication, which has really made a big impact on our weak heart muscle related congestive heart failure type, and have a lot of positive effects in people living longer and getting their heart stronger. Obviously, we have some other new medications which are called the SGLT2 inhibitors. Example would be empagliflozin and or Jardiance, and Farxiga is called dapagliflozin. Those are commonly used drugs. Those are new medicines that came out recently in the last couple of years or longer. And in addition, they have augmented our other medicines like beta blockers and spironolactone that we already had. In addition to that, from a device therapy standpoint, we have sensors nowadays that can monitor your volume status. Some of them are implantable sensors and some of them are external. Some of them are built into your defibrillator and pacemakers. And for our 5% patients who have advanced heart failure, 5% of all heart failure may have advanced heart failure, meaning that their hearts are really at the end of the line. For those patients, we have developments like an LVAD, which is a heart pump, which can be implanted surgically to help restore the blood supply, blood flow to the body. And transplantation field also has evolved over a period of years and decades. So long story short, I think certainly on the medication and device front, heart failure has evolved for the better. Our patients are living longer. We can make more of an impact on their treatment. In certain type of heart failure related to amyloidosis, we also have medications that can be prescribed, like tafamidis is one of them, that can help have an impact. So rhythm, it can be associated with heart failure, and management of rhythm problems also has helped people live longer or feel better. So certainly things have improved.
Which developments have had the most impact on you and your patients?
Medication would be the most impactful. The availability of medication, like I mentioned earlier, though, because majority of our patients are not advanced heart failure. I think that if you optimize their medications properly, I think that you can make the biggest impact on majority of your patients. So that'd be kind of my vote is, the lowest hanging fruit and the most impactful would be doing a good job or optimizing those medications appropriately as per the guidelines.
So many of these meds prevent surgery. Is that where we're going here or not?
I think so. I mean, if you optimize the medications properly, you may avoid future problems that may be more intense, like surgical options, right? Just as a side note, when it comes to the heart, I call them checking the boxes. You got to check all the boxes, okay? You cannot be sitting on blockages and just say, I'm going to treat them with medications and hopefully that will be enough. So if there are blockages and there are rhythm problems and there are valve problems that cannot be fixed with medication, some valve problems can get better with optimization of heart failure. But let's say if there's a structural abnormality with the valve, so you got to optimize the heart. You got to optimize on all of these fronts: medications, valves, blockages, rhythm. But in certain situations, medication optimization alone may be enough to prevent future surgical intervention. For example, the valve may get better as the heart gets stronger, and you may not need valve replacement or a clip in the future. So, yeah.
I thought one of the most interesting things one of your cardiologists on the program said or told us is that in the replacement of a valve, the original valve is just crushed and left in there, and a new valve is placed around it. And I thought, oh my gosh, that's really interesting. It's like a dump, a dump in the heart, in the heart circulation issue. So.
Exactly. It's like kind of like a stent. You put the stent in and crush all the junk to the side. And a valve can go into the aortic, stenosis and crush all the calcium and everything to the side. And it's a new valve now.
Well, what's the situation in heart transplants or replacements these days?
So the situation with heart transplant is in the couple of years, there's a new criteria for listing of transplantation for transplantation. So people who are the sickest of the sick, who require things like machines, and they can the ICU setting, they're on the top of the list. So people who are on ECMO or balloon pumps or other gadgets, they have to stay in the hospital, and those are highest in this list. There's a 7 statuses now, 1 to 7. And status 1 and 2 are those people that are the sickest of the sick, and they're most likely to get an organ transplant. That has improved allocation to sicker patients. And there are some other changes that were made regarding the geographical radius where donor hearts can come from and so on. But overall, it has been, I think, a positive change in the transplant field.
Interesting.
All right. Well, I think it's time for our last break.
I think it is too. You're listening to Health Matters with the Medicine Center Pharmacy.
Now, here's your host, Paul White.
Welcome back to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. Pharmacist Brad White, and I thank you for joining us. So let's get back to the last segment of the show, Doctor.
Yep.
All right, Doctor, we've talked about a lot of different things today, and I wondered, if you could kind of help us tie some things together with maybe what you see in patients on a daily basis, and if you have any common themes that, I don't know how many patients you see that say, boy, I wish I would have known X a couple of years ago, so I could have made some changes. Do you have conversations like that? And what would be some common takeaways for people listening today to take action today and put plans in place so that maybe they don't have to visit you as soon as they would if they didn't? So,
Yeah, I think that to summarize everything, I feel like, cardiovascular health is key for you for long life. I think that if you don't have cardiovascular disease yet, taking preventative measures with which we mentioned, weight loss, exercise, eating healthier, avoiding high risk food, and making those lifestyle changes early, seeing your physicians, whoever you're seeing for preventative care, making sure your cholesterol is checked, sure all of you're not diabetic, and make sure all of the tests are done along those lines. So take charge of your health early, and if you don't have cardiovascular disease yet, do preventative. Prevention is better than cure, as they say. But if you already have the cardiovascular disease, then making sure that you're following up with your cardiologist on a regular basis, making sure you're on all the right medications that hopefully the cardiologist will be putting you on, and following his recommendation or her recommendation carefully, prospectively, would be the best advice. I think if you have a strong family history and you do not have cardiovascular disease yet, it's probably best to reach out to your physicians early and taking charge of that situation, or making sure you don't have any disease process early would be kind of the recommendation. So that's kind of the summary of what I would say, with related to cardiovascular disease or heart failure. Some patients who do have heart failure, I think that, some of the common things I come across is that one of the misconceptions I think in the community is that, hey, I'm drinking a lot of water, I just need to drink a lot of fluid or to keep my kidneys flushed out because I'm taking a diuretic, and so on. And I think that kind of doesn't help us sometimes. And if you're drinking excessive amount of fluid, and especially if you're not being careful with salt or each of them, like either or, that can make you accumulate more fluid, and then we have to give you more diuretic, and then it kind of messes with the kidney. So trying to be careful with that. The less water sometimes you drink, and if you're not thirsty, don't force yourself to drink, may actually help us on the other side, because we don't have to use as much diuretics to prevent you from filling up with water. So that's one of the common, I think, thing that people. Now, if you don't have any heart disease and you don't have any heart failure per se, then then you can drink as much water as you want. But if you do have a diagnosis of failure, then I think you have to be careful with how much water or fluid, liquid, goes in.
Just to kind of tag something on here, unfortunately, we see many patients in the pharmacy who don't even have a primary care physician. So those that are listening today, if you haven't had an annual physical or a checkup, or you don't have a primary care physician, I would recommend that, maybe you stop in the pharmacy and we can try to help you find a physician that's taking patients, or maybe you talk to your insurance company and find out who's in network that's taking patients, because it is important to have those wellness checkups, because if you don't get those done, you might find yourself in a position where, you don't catch something early. And I'm guessing that most patients that come to see you, doctor, at your practice, they end up they need a referral, right? So you're going to have to work together with a primary care physician so that if you need advanced cardiac care, that you can get that care quickly and efficiently, and not before it's too late. But doctor, I wondered if you could also share some information about the locations that you and your team practice at, and maybe give us some background on locations so that people who need more information can get it easily.
Right. So we cover a pretty wide geographic territory. We go all the way to Alliance and Salem on the east side, down to Coshocton on the southern side. We go to Dover, practice. Some of the microsatellites we have, Louisville. I think we go to Hartville. We go to Hartville, and so on. So our and obviously North Canton, Massillon, and Canton, we are present. So our partners, we travel quite a bit to cover a big geographic territory. We are also, I think, looking at a mobile, van or whatever, where we actually may go to other facilities, other locations, which be inaccessible, or we may not have microsatellites there. So it's kind of a microsatellite on wheels kind of concept, which is kind of novel. So we want to go be out there for the community. Our accessibility is pretty good. Our appointments typically are available quickly. So we want to be accessible to our patients if they're running into issues. Especially in our heart failure side, we are also we try to get them in hopefully the same day or the next day if they're running into water issues. And same is true for our other practice. We tend to make an effort to try to see our patients sooner rather than later, so they're not waiting as an outpatient for long. And especially this accessibility, where we are actually going to their community, I think it's quite convenient for our patients. Many of them would prefer, hey, I'll see my doctor when he comes to Alliance, And I think that, yeah.
Do you have anything you want to just share that you're most excited about, that you've, new research you've learned about, or new technology that you think will be really helpful for patients coming up, or any current events that have just been exciting?
Yeah, I think that in general, I feel like the way there are new medications coming out in cardiology and new innovations coming out, I think in general, like cardiology is quite an exciting field from that particular standpoint. And I think, we are also participating in some research trials. I am seeing, without naming any particular names of medications, that there are other medications that may be like Entresto, for example, that are out there, and they may be even injectables that may be coming out in the future, if they're obviously approved by FDA and they're showing benefit in large randomized trials, that may make a huge impact on our patients who have congestive heart failure. And it may actually take the compliance out of the equation as well, if you can inject them once a month and make an impact which is bigger than even Entresto. That may be huge in helping people live longer and so on. I personally think, though, that preventative cardiology is where we can really make an impact in our community, changing the way our children, changing the way our college students think, inculcating lifestyle changes at an early age. I personally think that if we can even have a curriculum during our schooling system, high school, middle school, and college, where we have a certain curriculum dedicated to preventative medicine, our healthcare costs may come down. Our overall burden on the society, on Medicare and so on, may actually come down. And that's kind of where I feel like most of our impact, most of our care should focus on that. I think that when they come to us already, that's kind of already too late. And I think if we can prevent, things from happening before, for example, obesity, if we can somehow target that, I think that there are some drugs out there, but I feel like that's kind of would be very exciting to me if we can somehow make huge changes on the preventative side, where cardiologists, even before they ever come to a point where they need cardiologists, they can be, they can be improved upon before that. So, but yeah, to answer your question, I think there are certainly a lot of things that, that are out there that are exciting, and there are more to come in the future.
Okay, I've been a pharmacist for over 50 years. I'm from the digitalis area, the crude digitalis products. I'm thinking we dispensed tons of that, years ago.
Right.
And hydralazine and some of the other stuff. I'm thinking, oh my God, how interesting that is now, really with some fantastic drugs. And I think we're out of time, aren't we, Brad? Okay.
Yeah, we are.
Thank you, Dr. Qureshi, for joining us today. Very interesting. If you suspect you have a medical issue, please contact your healthcare provider. Thanks to Aultman Health Systems and our listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we'll see you again next Friday right here on News Talk 1480 WHBC.
Thank you.
Thank you again, Doctor.
Thanks, Doctor.
Very good. Thank you.
Thank you.